This is one of our bigger projects, the Better Start National Science Challenge. They have four themes in the Better Start National Science Challenge. One is called Healthy Weight, one is called Resilient Teens, and one is called Successful Learning and Literacy. So if you've got a sort of a BC one, a mental health one, and an education one. And then sitting across those is the Big Data team, which is where we sit. So that's led by Barry Taylor at the Dunedin School of Medicine. Rick kind of runs things at the Dunedin School of Medicine, and those are the other workers there. I kind of run things to some extent in Auckland, working with Nicola, who was here and had to shoot away, Steph, and also Cherie, who does work out of the University of Otago, Wellington. Whereas in Dunedin, a lot of the work is done by Nick, and also Justine Rose and Jessie Kokoa. So our role is to work with the three other themes, some substantive themes, to use big data to assess time trends, spatial distribution, and ask other key questions that can only really be answered with whole population data. And for that we're using the integrated data infrastructure. And what we've tended to focus on, for various reasons in terms of data availability, for healthy weight we focus on the before school check, which is, it's got the only kind of nationwide screen of obesity at any age in the country. And for those of you who've been reading the New Zealand Herald this week, they've got a sort of running series on child health that's touched on some of the work that Nicola and Cherie and others of us have done in that area. Also touched on the before school check generally. For resilient teens, using pharmaceutical data, that's what Steph's going to talk about. And for successful learning and literacy, we've focused a little bit on the before school check data, as I'll talk about later, and also some work we're starting to do on the schools data. So yeah, the idea is we sit across the other three themes there. For those who don't know, the integrated data infrastructure managed by Stats New Zealand, it's a whole population data set of an ever-resident population in New Zealand where they link different administrative data sources at the individual level, as well as having a couple of surveys and the whole census in there. So you've got benefit data, you've got health data, you've got education data, you've got the census population data, you've got Ministry of Justice data, etc. Where you've had contact with those sectors, your data would be in there and linked at the individual level, made available to researchers under the strict conditions that New Zealand operate under, 5 states that I mentioned earlier. Disclaimer that you would have seen earlier from Olivia, I think. I'm about to present some data from the IDI, and that's the disclaimer you need to show when you do that. Okay, so what I'm going to do is run through 4 things that we've been working on. One touching on each of the themes, and one more generic. I'll touch on the generic one first. We've done most of our work, certainly at Compass, and in Dunedin as well, their big data work is mostly focused on the before school check, which is, as I said, is a nationwide screen of 4-year-olds to check vision, hearing, height, weight, behaviour, any problems that the parents noticed, a couple of other immunisation, and a couple of other bits and pieces. It's a nationwide screen, so everyone can do it, but what we wanted to look at is the extent to which everyone does. We know that the coverage is relatively high, but is it differential across certain factors? The before school check itself was established in 2008, September, but took a while to get underway in all DHBs in the country. What I'm going to present are data from 2010-11 to 2015-16, where we get at least 70% coverage across those years. And eligible children are those who are enrolled with a PHO, Primary Health Organisation, on their 4th birthday, and they get a letter to their parents saying, your child is due for their before school check, would you like to bring them in, please? Of course, if you're not enrolled with a PHO, you never get that letter, so that's one way that you'd miss out on a before school check. So as I said, there's, and I'll present things in these groupings actually. Vision and hearing tests, that was the focus of Monday's edition of the New Zealand Herald. Nurse checks, these are sometimes done on different days as well. So you need to go along potentially twice for your before school check. So the nurse check will do a height and weight of the child, do a lift the lip dental assessment, looking inside their mouth for signs of caries, check that they're up to date on the immunisations, ask the parents to fill out something called the Parents' Evaluation of Developmental Status, which reports any problems that the parents think that the child has, as well as the Strengths and Difficulties Questionnaire, which is a child behaviour checklist type instrument that assesses problems with anxiety, problems with externalising behaviours, those sorts of things. That's filled out by the parent when they bring the child along, but also they send a copy of it to the early childhood teacher of the child if the child has one. So I'm going to show the extent to which we've got good coverage of the before school check across those different checks, the vision and hearing, the nurse, and the early childhood education. Okay, maybe you can, maybe you can't see those numbers there, but looking across the 4 fiscal years there from 2011-12, 2014-15, what I've used as our denominator here is a kind of a denominator that was derived as part of the Census Transformation Project and was developed further by Cherie Gibb and Jinping Zhao to work out basically who are all the people in the country at any one time, based on evidence that they're in the country by accessing particular services. So those proportions that I'm showing there, or percentages, are out of this denominator of who we think are 4-year-olds in the country in those particular fiscal years. So you can see coverage is going up, and to the point where at least 90% of children are getting a vision and hearing check now. Slightly less than that, 85, 86, 87% getting a nurse check, and only 50 to 60%, above 60% now, are returning a Strengths and Difficulties questionnaire from the early childhood education teacher. And there are differentials by ethnicity here, relatively small ones, but still differentials. So you are slightly more likely to miss out on a test, or slightly less likely to get a test if you're a Māori Pacific child compared to a European or Asian child. Same for vision health test, the nurse test, and a real discrepancy with who returns a Strengths and Difficulties questionnaire from the Early Childhood Education Centre. Similarly there, you're seeing a gradient across deprivation. Olivia, I think, before talked about the NZ Index of Deprivation, which has got, the scale's got 10 levels. We broke it into 5 quintiles, and I'll show the quintiles going this way, where you've got the least deprived and the most deprived, and you can see there's a deprivation gradient there. A relatively mild one, except more pronounced for the teacher return form. So, conclusions from that is not all children are receiving a before school check. Most children are. Most are getting the vision hearing test, certainly. And what that means is that benefits from the before school check will be unevenly spread across the population. Now, work that we didn't do, but other people have done. I should say that this is work done by Cherie Gibb, led this paper. Focus group that they got a research company to do, the Ministry of Health, found that low-income Māori Pacific parents identified concerns where they didn't quite know the relevance of the before school check. So to some extent, they argued, this was a marketing issue or a communications issue. It wasn't communicated well, the importance of the before school check and why it's important for your child to have one, so it can pick up on issues that the child may be having. There was also issues about language and cultural understanding when they go along to a check, and also that they'll be judged. So it's set up as a good thing, but there's a fear amongst some parents that they and their children will be judged by what is found out as part of the before school check. Okay, so that's the general one. Moving on now to a healthy weight assessment. And this is probably the area we've done the most in, so I'll just focus on one. And that is looking at community level trends in obesity across New Zealand territorial authorities. Nicola had led a paper earlier showing that overall preschool obesity is tracking down in New Zealand. It's dropped by about 2 percentage points over 5 years. What we didn't know from that analysis was whether that change, that improvement, is kind of equal across different communities in the country. What we were interested in was finding whether there were certain communities that were doing well and looking then to see what was going on in those communities that could possibly be replicated across other communities. So the 3 questions we want to look at is, do levels of childhood obesity vary between communities in New Zealand? That is the overall start point. Do trends in childhood obesity vary between communities in New Zealand? That is the extent to which they're going up and down. And to what extent can variations in obesity between communities be explained by differences in the socioeconomic deprivation and ethnic composition and urbanicity of those areas? For those who are interested, we've actually put this into a Shiny app where you can go there and look at how different communities are tracking in terms of the slope, whether they're going up and down their obesity, where dark green means they're going down a lot and dark red means they're either going up or staying flat. And similar over here, but this is the overall level rather than whether it's going up or down. So the start point, to some extent, where they started. But, cut a long story short, what we found, which was interesting to us, is that there's far greater variability in the overall levels between different communities in New Zealand, and very little variability between the extent to which they're going up or down. Most are tracking down slightly. There's very little variation there. 11 times the variation in overall level between how much variation there is going up and down. So, I mean, the overall level ranged from 10% to over 25%, so 2.5-fold difference between different communities. But the pattern of change over time was similar across communities, with the majority of communities experiencing a similar rate of decline. We found that more of a third of the variation in community obesity prevalence, that's not the extent with which they're going up or down, but the overall level, could be explained by the socioeconomic and urban composition of the community, and another 10% by the ethnic composition of the community. Okay, moving on, a paper that Nick Bowden out of Otago is working on, it's out for review at the moment, is looking at the extent to which antidepressant dispensing has changed over time, specifically focusing on children and young people, so 0 to 24-year-olds. And the extent to which this varies across different age, gender, and ethnic and socioeconomic groups in New Zealand, similar to what we showed before for the who's getting the before-school check. I'm not a medic, but these are some of the medicines that we counted in here, the common medicines that are prescribed as antidepressants. You've got your SSRIs, such as fluoxetine, monoamine oxidase inhibitors, the tricyclic antidepressants, the selective serotonin uptake inhibitors, tetracyclics, and other ones. So, what we've got here is trends for by age and gender. What you see generally, though, is it's going up over time. But overall, there's about a 49% increase in dispensing. So 49% increase in the proportion of children and young people who are getting a dispensing for an antidepressant. Dotted lines are female, solid lines male. The red ones here are the eldest age group, 18 to 24s. So you can see that they've gone out at about the same rate as other groups, about the 49% there, but big differences between men and women in terms of who's getting an antidepressant. Over here you can see what this means here is roughly about 10%, but under 10% I think of females aged 18 to 24 were receiving a dispensing for antidepressant. You might say, well, how does that relate to how many females aged 18 to 24 actually have depression? In work I've done outside of the Better Start National Science Challenge, I would say that it's in the 20 to 30% mark. Have at least one major depressive episode for females of this age. There's other ways to treat depression, obviously, other than just antidepressants. And thankfully, not many children less than the age of 12 are getting antidepressant. And very few, around the 2 to 3% mark of girls aged 13 to 17 are receiving an antidepressant. This is kind of interesting though. If you are New Zealand European, you have about double the prevalence of being dispensed antidepressant than if you are Māori, and about 3 times than if you are Pacific or Asian. Now, I don't think the depression prevalences show these same trends. So it isn't the case that New Zealand European children have 3 times the depression rate of Asian and Pacific children, but they certainly have 3 times the dispensing rate. And when you look at deprivation, there's really not a lot of difference. A lot of convergence here across 80% of the population. That's NZ depth quintiles 1 through 4. But NZ depth 5, that's the most deprived groups, are, what's that, about 25% less likely to receive an antidepressant. Suggests this, and there is no evidence that this group has less prevalence of depression. Suggesting that there may be some access barriers here, or greater willingness to dispense to these groups as opposed to these groups. Okay, so just to conclude on that one, trends in antidepressant dispensing to children and young people have gone up by about 50% over 9 years. There is variation by all the factors we looked at: gender, age, ethnicity, socioeconomic status. A doubling prevalence of females versus males, which was known already. Dispensing far higher for New Zealand and European than Māori and Pacific, or Pacific and Asian especially. And overall lower dispensing prevalence for NZ depth quintile 5, which I would suggest might be an access issue. Just to finish up then, so we've gone through a look at the before school check, we've gone through healthy weight, we've gone through resilient teens, now on to successful learning and literacy. And actually, I've got that wrong, that should just say literacy interventions there. We did 2 papers actually, one looking at the extent to which children who get literacy intervention the first 2 years of schooling could be identified using before school check data. One looked at the whole population, which is one I'm about to summarise, and another one that looked at the Pacific population specifically, which I won't summarise much, so I've got a bit of an error in the title there, sorry. So the aim of this, as I just foreshadowed, was to evaluate the efficacy of the before school check indicators as a screen for early primary school literacy interventions. So what's happening at the moment is children are getting to school and they're discovering within a year or so of children getting to school that they actually need a little bit of help. What if we could find out before that these children were in need of a bit of extra support before they even get to school? Can the before school check be used for that? And the answer to that question basically is no. There are differences that you can find in factors in the before school check, both demographic factors, but also some of those things I went through before in terms of vision and hearing and parents' evaluation of developmental scale and the strengths and difficulties questionnaire. But the predictive ability of the before school check data is poor for distinguishing which children get a literacy intervention and which children don't. When we did this in Pacific children, as the title before suggested I was going to tell you about, the prediction was still poor, if anything poorer, 0.592, which means if you've got a child in front of you who's had a literacy intervention and a child in front of you who hasn't had a literacy intervention, and all you know about those children is what you get from the before school check, you'd pick the right child 59% of the time. So not really good discrimination. Basic conclusion there is the before school check as it is currently implemented is not a useful marker of who needs or perhaps receives a literacy intervention. All we know is who gets a literacy intervention. We don't know anything about need, and there's various people have suggested to us that they're not distributed necessarily strictly by need, who gets a literacy intervention. Okay, so that's been a quick summary of the work that we're doing in the before school check, where we develop research projects with each of the themes, and we go away and do the work that needs to be done, analysing IDI data typically and writing it up to look at trends and other sorts of things. Other projects that we've worked on that I haven't described, one that's in review now but I presented last year at the colloquium, is the extent to which children taking antibiotics have increased risk of obesity, for which there is some literature related to wiping out of the gut microbiome. We basically find when you do the analyses well, and that is compare within families between siblings who have different amounts of antibiotics, you see no association there. Also, Nicola, who was here earlier, she's looked at, there's known to be large ethnic disparities in obesity. She wanted to look at the extent to which socioeconomic and other factors can explain those ethnic disparities, and she could explain around 50% for Māori versus New Zealand European, and about a third for Pacific versus New Zealand European. Steph's coming up, going to talk about trends in ADHD medication dispensing. Nick's working on a paper to see The extent to which you can identify mental health cases with the data that are available in the IDI, and there's some things that are missing there, notably primary healthcare data. And similarly, looking at the extent to which you can identify autism spectrum disorder cases, which Nick's working on for his PhD. Another thing, colleague Eileen is working on with a collaborator, Rebecca Slykerman, is again looking at this gut microbiome issue where the caesarean births, there's a suggestion that caesarean births through various mechanisms via the gut biome produce cognition. And so we're looking at the extent to which caesarean births can be associated with later child education outcomes. And to be honest, I'm finding a heck of a lot going on there. Future work will explore intergenerational impacts, the extent to which what's going on in families affects the children. And also building on the work that we've done at Compass using microsimulation to see what sort of cost benefits there are of different interventions on childhood outcomes.